IPSS-M for MDS. Thank you for joining us. My name is Lee Clark, Director of Patient Services, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generosity of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the webinar today. I'd like to let you know about a few opportunities that we have here at the Foundation, additional educational opportunities and opportunities to bring awareness to bone marrow failure diseases. First, we offer several patient and family conferences throughout the year. All of our conferences are hybrid, so you're able to participate in person or in the comforts of your home. Our next conference will happen in Salt Lake City, Utah, and that will be on July the 15th, 2013. Registration is currently open for our Salt Lake City conference, and you can register directly on our website. Next, we have several support groups that are still happening throughout the month. These are the support groups you can see here on your screen that are left for the month of May, and our June support groups are already posted. Once you register for a support group, you will receive a confirmation email, and in that email will be the information to join virtually to participate in the group. Next, we have 2 March for Marrows, which are left in 2023. Our March for Marrow in September will be happening in New Jersey, and then in October, our March for Marrow will be in Virginia. You can register or find more information about how to join one of our walks, which will be on our website at AAMDS.org. Now let's get to the webinar. So immediately following the presentation, there will be a question and answer session. To submit a question, you can do that at any time during the presentation using the Q&A icon in the engagement panel on your right. To submit a question or comment, just type in the Q&A box, and when you've finished typing, just hit enter. We will do our best to get to everyone's questions today. When asking questions, I do ask that you do 2 things to help me manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our speaker cannot answer any specific questions related to your personal health care. Our specialist today is Gail Roboz. Dr. Roboz is a professor of medicine and the director of the Clinical and Translational Leukemia Program at Weill Medical College of Cornell University and the New York Presbyterian Hospital in New York City. Dr. Roboz graduated summa cum laude from Yale University and received her medical degree from the Mount Sinai School of Medicine in New York, where she was elected to the Alpha Omega Alpha Honor Medical Society and achieved the highest academic standing in the graduating class. She completed her internship in internal medicine at the Beth Israel Hospital in Boston and residency in internal medicine at New York Presbyterian Hospital. Dr. Roboz completed her fellowship in hematology and medical oncology at New York Presbyterian Hospital. Her research interests are in developmental therapeutics for acute leukemia, myelodysplastic syndromes, and myeloproliferative diseases. With that said, it is my extreme pleasure to welcome Dr. Roboz. Thank you, Dr. Roboz, for joining us today.
Thank you very much for having me, Lee. And now comes the scary part, which is to see if I can actually successfully share my screen. So that hopefully worked. Hi, everybody. Thank you for the invitation, and it's a pleasure to be here today. I'm actually speaking live from my office. So this virtual background is blurring the chaos that is behind me in my office. And occasionally, despite the sign on my door, people do tend to bang on it ruthlessly. So I'm going to apologize in advance if there is any chaos today. But, we try to have these webinars be timely topics for patients, and the subject of the IPSS-M keeps coming up. So I offered to give this talk. And then, of course, as the talk got closer, I said, all right, well, now I have to write an actual talk about this topic. So I decided to do what all of my friends, family, and what everybody in the newspaper seems to be doing, which is to see if I could easily be replaced by artificial intelligence, and to see what would happen if I ask ChatGPT what the IPSS-M is. And I figured that'll be fast. Maybe AI will write my lecture for me. So I kind of read the instructions. I haven't really used this before, and it asked all kinds of personal information from me too. So I'm sure that it has now hacked all of my information. But at any rate, I typed in, explain the IPSS-M. And the machine wrote back to me, I'm sorry, but as of my last knowledge update in September 2021, I don't have any information about an IPSS-M. And then it kind of goes on to say that, well, if it's been updated or developed after 2021, I don't have any details about it. This is now the machine talking to me. So I kind of said, oh, well, good. At least I haven't been replaced immediately yet by the computer. But it kind of bothered me because September 2021, it still should have known something. And I figured maybe I did it wrong. And I opened Pandora's box and I asked it again. Instead of saying in the previous one, I said, explain it. I said, what is the IPSS-M? And the computer exploded. Well, first it apologized to me and it said, I apologize for the confusion in my previous response, which was very odd to me to be having this conversation with my laptop. But it then proceeded to give a lot of information about the IPSS-M. And it says it refers to the International Prognostic Scoring System for Myelodysplastic Syndromes, which is a risk assessment tool used to evaluate the prognosis and predict the overall survival of patients with MDS. Well, that's pretty well written. Then it says the IPSS-M is an updated version of the original IPSS and provides a more refined and accurate risk stratification for MDS patients. It takes into account additional clinical and laboratory parameters to classify patients into different risk strategies. And then it proceeds to go on and on and on with what is actually a lot of accurate information. So part of me says, okay, well, bye, have a nice day. You can have the rest of this lecture talking to your laptop and asking ChatGPT. But I did decide to write my own lecture instead and to go on with what I hope will be some useful explanations both about MDS and about this new tool. I will say, though, that the fact that the robot has already passed the medical boards is an interesting piece of information. And I will congratulate the robot at the end of the large paragraph on IPSS-M. It actually does have a very complete comment about how it doesn't give advice. It's not a doctor. It's supposed to be a tool. And it does say to ask someone, I guess a human, who actually knows what they're talking about. So that's probably a good thing. And we're going to see if Dr. AI is any better than Dr. Google. Dr. Google, I actually think, should be fired most of the time. So just for anyone who's new in the group, who might not even know what MDS is, let alone the IPSS-M. So let's talk for a minute about the definition of MDS, or myelodysplastic syndrome. And before I get to the hard part, which is the rest of the slide, myelo means bone marrow. Dysplastic means the cells look funny under the microscope. And syndrome, I like to tell people, means that this is not just one disease. It's a group of diseases. And if you come to my office, and I happen to know that many of the people logged into this call do actually come to my office, you'll see that there are patients with MDS who are quite different from each other. The clinical behavior of the disease and what patients experiences is very different, which is why this really isn't only one disease. It's a group of clonal hematopoietic stem cell disorders. And what that means is that this is a malignancy. So clonal, unfortunately, means malignant or cancer. It is a type of cancer. It's not bone cancer. It's a cancer of the bone marrow. And it's characterized by ineffective hematopoiesis, which means inadequate making of blood cells, progressive pancytopenia, which means that most patients actually do have worsening white blood cells, red blood cells, platelets, or some combination of the blood counts over time. Parentheses, every once in a while, patients with MDS can also have elevated white blood cell count, but that's less common. And there is a propensity for the disease to transform to acute myeloid leukemia, or AML, which is a complication that patients worry about all the time, because leukemia certainly sounds like a bad and serious thing, which it is. But actually, it's only about a third of patients with MDS who eventually transform to full-blown leukemia, and there are plenty of complications and issues with the disease before leukemic transformation happens. That said, and I will address this a little bit later in the talk, the lines between MDS and AML are becoming increasingly blurred, and there is not, in fact, a hard line in the sand of where MDS ends and where AML begins, and I'll talk about that a little bit. I think the last point in red is something just to mention, that there are systemic inflammatory and autoimmune conditions that actually can overlap with MDS a lot. And we do get referrals from our internal medicine and rheumatology colleagues where the patient might have a syndrome of skin problems or lesions or joint issues or other problems that are in addition to having abnormal blood findings. And we work with internal medicine and rheumatology colleagues to really put a specific diagnosis on whether the patient has, in addition to whatever their other condition is, myelodysplastic syndrome, or whether there is some type of overlap. And the overlap here is what I want to point out. This is an alphabet soup of difficult to pronounce diseases: acute myeloid leukemia, myeloproliferative diseases, PNH, paroxysmal nocturnal hemoglobinuria, autoimmune diseases, aplastic anemia, LGL. All of this sounds like alphabet soup, and they certainly sound like they should be very different and easy to distinguish from each other. And actually, they're not. There is a lot of overlap between aplastic anemia, MDS, and these other diseases. And you shouldn't necessarily be worried if you go from one doctor to another and one person says aplastic anemia, the other person says MDS. They sound incredibly different, but it's very important to go over with your doctors what the similarities and differences are in some of these overlapping diseases and how your specific diagnosis has been made. And I can tell you there's quite a bit of arguing that goes on for many patients in how to distinguish between these different categories. It's not so obvious. In particular, these lines between MDS here in yellow and AML in red, which is very upsetting to patients because leukemia does sound so scary, but these lines are quite blurred. And some of the updated classification battles, which I'll talk about, are going to specifically address those issues. So MDS in the United States is called a rare disease. It's not rare in my office, but it's only, around 20,000 cases a year. I think a lot of this is still because MDS is ultimately underdiagnosed. There are plenty of patients in offices with low blood counts who might be much older patients with other medical problems that are kind of confusing the issue of diagnosing their blood counts. But this is actually a disease that likely is much more out there than what we really know. Most patients are older than 60, but it can actually affect anyone, children, even, and adolescents. And about a third have progression to AML. And the clinical syndrome of the disease is really the question here. That is your specific disease behaving like a total bone marrow failure situation where there's no production of white cells, red cells, platelets, or is it something that is earlier on in the course that might have a diagnosis called MDS, and but still have some remaining bone marrow function. Survival rates are actually very, very variable here, and these numbers here of 6 years for lower risk patients and 5 months for higher risk patients, I leave them on the slide because that's what you're going to see if you access websites. But I got to tell you, these are more often wrong than right. And I deal every single day with patients coming into the office who told that they have 6 months to live and they've been bugging me for 6 years. And the opposite, that patients who are predicted to have low risk disease with very prolonged survival, and yet they have problems from MDS beforehand. So I'm going to open with saying and close with saying that we're not to the robots yet. And there has to be a lot of individual decision making based on how a particular patient's disease is behaving rather than just following along average survival curves. So most of the time, we don't know why people get MDS. And many of the patients on this call will go like this and just sort of throw their arms up. They have no idea why they have it. Prior exposure to chemotherapy and radiation are definitely risk factors. And as we cure patients from solid tumors with better chemo and radiation techniques, the price to pay could be increasing incidence of MDS. Advancing age is definitely a risk factor, and we accumulate mutations. All of us do after 30. Well, some of those mutations are accumulating more and more associated with actual disease of the bone marrow as people get older. There are congenital diseases that are associated with MDS. These are mostly rare, and many of the time the pediatricians will be diagnosing this, or sometimes when we see a very young patient come in, we will pick up an as yet undiagnosed congenital disease. Environmental toxins come up a lot, organic solvents, benzene. If you worked in a gas station for one summer when you were 12, that probably wasn't it, but we're talking about, significant exposure over many years. Agent Orange is always a question that has a lot of controversy behind it, and the World Trade Center exposure, although MDS and bone marrow failure states are now listed as World Trade covered diseases. Of course, it's very difficult to point at causality rather than association there. I bring up familial syndromes because we used to tell people that diseases like MDS and leukemia weren't associated with familial or inherited syndromes, and we actually don't think that's true. There are increasingly identified syndromes, sometimes involving mutational abnormalities. I listed RUNX1 and DDX41, where you have multiple family members with blood problems that are identified. And I think doctors are becoming increasingly good at asking patients for their family history. This is especially relevant if you're going to be considered for bone marrow transplant, because if there are multiple family members with blood issues, and if there is consideration of the potential use of a family donor for a bone marrow transplant, it's particularly important not to be transplanting the same disease into the person that you're trying to cure. So we are looking much more intensively for any kind of sign that family members might be affected. So signs, symptoms, and clinical features of MDS, often there's nothing. I mean, often we just don't find anything, but sometimes there is a clue in the blood counts, for example, anemia, that would prompt evaluation in hematology. You can have fatigue. I would say that all my office complains of fatigue. I mean, the doctors complain of fatigue too, but pretty much everybody with a bone marrow failure disorder does complain of fatigue. It doesn't always track with the anemia. There are patients who bounce in with a hemoglobin of 8 feeling really great, and there are other patients who come in hardly able to stand up with the same level of anemia. So it's very, very individual what you might experience with certain blood numbers that will come back on a CBC. Some patients can have bruising, bleeding, fevers, bone pain, shortness of breath, frequent infections. These are all, these can happen in a million other things, though. There are a lot of things that cause fever. There are a lot of things that cause shortness of breath. So the specificity here is difficult because there are all kinds of things that could pop up in different disorders, but it's kind of putting together for an individual patient what that patient is experiencing to try to figure out what is the clinical problem to solve. If somebody is having lots of fevers and night sweats and shortness of breath, those clinical features are different from somebody with different symptoms, and the tailoring of the therapy is hopefully definitely going to try to address specifically what's bothering an individual patient. Now, there's no doubt about it, and this has been studied, and certainly many of the people on the call can speak to this, that there is an impact of MDS on quality of life, pain, discomfort, mobility issues, certainly anxiety about having a problem and not knowing exactly when, whether it's going to remain stable or get worse. There can actually be depression from that as well. And I think that many people would just feel that they just are not performing at what they would like to be or what they had formerly been. So their usual activities are impacted by it. So this is, even when on paper there might not necessarily be specific evidence of aggressive disease or transformation to leukemia or increasing blasts on a bone marrow biopsy, it doesn't mean you're not feeling lousy from it. And I think patients have to be listened to and heard in terms of what is the impact of the disease on their own quality of life. That said, there are many patients with MDS who are older and who have myriad other medical problems, cardiovascular issues, pulmonary issues, other problems. And sometimes it can be really tough to tease out what is causing what. You can have, hypertension, diabetes, cardiovascular issues, which are making a certain level of anemia, for example, feel worse for an individual patient. So it's pretty important to take into account all medications and all medical issues when kind of trying to come up with an assessment of the impact of MDS in particular on a patient. Now, as I started out mentioning, and the whole point of the talk is to try to figure out, okay, what to do with this disease. So you've got the disease, a diagnosis has been made. So now you want to know, well, am I going to be okay or am I not going to be okay? And there have been efforts over the last decades to actually come up with a prognostic scoring system. Now, my patients who are on the line will giggle when I say, because I say this frequently, that I don't want any of this to be used as an expiration date. A patient is not a loaf of bread. And I think that all of these things are misused when somebody walks out of the office with a number circled about how long they're going to live, because we are not, with any of the prognostic scoring systems that I'm going to discuss with you, we don't have that level of precision or accuracy. And the one thing that I want to say, and I'm going to repeat myself on this, that prognostic scoring systems and outcomes are by definition reflections of the treatments that we have available. So if we look at how patients are doing over time, whether or not, for example, here in the IPSS, we're looking at cytogenetics, marrow blasts, hemoglobin, platelet count, an absolute neutrophil count. And we put this all together and come out with an assessment of median survival and an assessment of the risk of transformation to AML. But these data are based on the patients being treated with the treatments that we have available. So everything that I'm going to tell you, including about the IPSS-M, is going to be fundamentally interactive with how our treatments are evolving. What do we have available now? What's likely to be the outcome with the treatments that we have now? And then this could blow up and absolutely change in the future. And there are aspects of the biology of the disease, cytogenetic and mutational abnormalities, which might be better fixed by certain treatments. And I will go over what I mean there. When you look at the RIPSS, the revised IPSS, it's taking into account those parameters. And for those of you who hang out with hematologists, you may actually know your cytogenetics, marrow blasts, hemoglobin, platelet count, and absolute neutrophil count. And that gives you an assessment of risk. Most of the time, again, the risk is not meant to tell you how long you're going to live, but it is important to understand whether we think that this is going to be a rapidly progressive disease for which curative therapy in the form of a stem cell transplant might be on the table. If you're 85, it's not on the table because we're probably going to hurt you with a transplant, not help you with it. But if you're 25 and if you're predicted to have a disease that's going to ruin your bone marrow quickly, we are going to start thinking about more aggressive therapies. And again, survival curves are tough to look at here, but the point is that if you have higher, very high risk disease, this is something that doesn't go on for 20 years at a time. And we want to start thinking for younger patients about what do we have in terms of therapies that can try to cure the problem, because treating it with medication, improving bone marrow function, is not going to be good enough. This will become life-threatening. Now, if we move to the next slide, we can see how the field started moving forward, because the previous slide took into account factors other than mutations. And what started to become clear over the last the last 15 years or so, approaching 20 actually, is that we started with next generation sequencing technologies being able to detect the presence of mutational abnormalities in MDS. And this is a whole alphabet soup of different ones. You may or may not see your own mutations represented here, but basically, once we started looking for things, we found lots of different mutations that were associated with the disease. And over time, there is an understanding, or an increasing understanding, of what is the impact of a particular mutation on MDS. I can tell you there's an arms race in institutions to sort of, who's got the most mutations on their panel. And I have patients all the time coming in with mutational reports that might even have 200 genes on them. We don't know what to do with most of that information. It is very common to detect abnormalities, and we don't know if they're important or not. And just because a gene is mutated doesn't necessarily mean that that's bad news. Most people hear the word mutation and they're immediately thinking bad news. That's not necessarily the case at all. There are some mutational abnormalities or mutations that are identified that are associated actually with better news. The point is that half the time, I kind of throw my hands up and say, I have no idea what this gene is or why it's mutated. We picked it up because the testing is getting really good at picking things up, but that doesn't necessarily mean that for an individual patient, it is of prognostic or therapeutic relevance. Now, the slides get more complicated because the field is getting more complicated. And what we've started learning is that for certain genes, we know a little bit more about what their frequency is. We see here written prognosis, good, bad, unknown. These are actually really to be taken with a grain of salt. This slide should have a large grain of salt on it. If I knew how to put it on it, I would do that and have it waving at you. Because, for example, ASXL1, right next to it says poor prognosis. Maybe yes, maybe no. I have plenty of patients with ASXL1 mutations who are doing just fine. So these are not absolutes. We don't know the answer for everything, how it interacts with other factors. And this is where I think actually having a doctor is important, because just because you have a mutation on the page does not necessarily mean that the disease is going to behave according to these curves. We know other things, though, when we start looking at mutations, which is that some of them offer the possibility of having directed drug therapy. Now, here, too, if you have an IDH1 mutation, we have an IDH1 inhibitor. It's called ivosidenib. It's not even FDA approved yet for MDS, but most patients say, oh, I want to have a mutation that's an IDH1 or an IDH2 because there's a drug for that. There, too, mutations can be in families. They can be in not families as in inherited, but in the context of other mutations. You might have multiple mutations that go together. That doesn't necessarily mean that one drug is going to work. And the problem, and the reason that I put a table like this up here, is that patients often get, depending on which commercial lab is doing the testing, the patients will often get back a report that has a mutation and then a treatment. It's not so clear. Trust me when I tell you that just because you have an SF3B1 mutation, luspatercept may be a great choice for you, but it may not. Just because you have an IDH1 mutation, it doesn't necessarily mean you will be treated with ivosidenib. So these things are in front of you in black and white. They are not black and white. It's quite complicated to actually figure out in the current 2023 what might be the best choice for a patient. That said, we do know that for certain mutational abnormalities, we're worried about the marrow function getting worse quickly. And we do think more about stem cell transplantation for patients with certain panels of mutational abnormalities, if they are candidates for potentially curative therapy with a transplant, we do think about it. And the point of this is to try to learn and to understand and to develop in the world of drug development. How can we be a little bit more tailored about the therapeutic choices to target a patient's particular biology? Now, things have gotten a lot more confusing in the last year. If you didn't think what I just said was confusing, wait till you see this. So within the last several months, there were released in the sort of second half of 2022, there were updates to what's called the WHO, or the World Health Organization, and the ICC, is a second major international consensus classification that works on classifying the pathology, the pathologic findings of MDS. This is the technical term for this situation is it's a mess, because the WHO and the ICC, both made up of all of the prominent, important people in the field of MDS, have come out with two very similar but not exactly the same classifications. And the field is actually in a bit of an editorial battle at the moment. If you follow this, there are one editorial after another discussing how challenging this is going to be for patients. Because, for example, and let me just try to unpack what this slide means. If you go to the blast count, most patients with MDS have gotten used to it, that 20% represents acute leukemia. Does that mean that if you have 19% blasts, everything is okay? No, that is still of concern, but there has been for the last many years a designation that if you have over 20% blasts in the marrow, you're going to be called AML, or acute leukemia. If you have less than 20%, and it's going to be called MDS. But here, unfortunately, these different classifications are going to have different terminologies for this. So if you have a pathologist who's reading your slides, who's giving you a report, and you have 15% blasts, if you have a WHO pathologist, they're going to call you MDS with increased blasts 2. And if somebody from the ICC is reading it, it's going to be called MDS/AML. I have to tell you, I've wanted to run away from clinic so many times recently to try to explain to a patient, how do you possibly have a disease with a slash in it? What is MDS/AML? The doctors can't figure this out, that whether I have MDS or AML? It's hard, it's blurred, and I think it's causing actually a tremendous amount of anxiety for patients. I really worry about the Freedom of Information Act, and some of the very immediate access to these reports is stressing people out. And I suspect that I can't see any of you, but there might be some nodding going on, because if you get back a report from one opinion that says you have MDS-IB2 and another opinion that says you have MDS/AML, what does one do with that? How to figure it out? What is the doctor actually thinking that I have? And it's even worse, because depending on whether there are certain specific mutations, SF3B1, TP53, the classification of this is resulting in a lot of noise. And I can only encourage the patients, talk to your doctor about therapy options. Don't get lost in classifications, because it is very stressful. And the doctors are stressed about it too, because honestly, some of these things are probably a distinction without a difference. Nonetheless, it's very jarring for patients to get reports back that seem or feel so different. But wait, it's worse, because there are 3 different molecular risk stratification tools for patients to add the molecular considerations onto what I just said. And not only that, but we are in a world where everything has an online calculator. So you can actually go on, if you Google, which you shouldn't, but if you Google molecular risk stratification in MDS, you will be able to plug your own information into a molecular stratification. But what you should know is that this too, it's not an absolute. There are 3 different ones, and they all have important subtleties, which are way beyond this call. My fellows don't even understand the subtle differences between them. But if you go on to mdsriskmodel.com and you would like to stress yourself out, here's what's going to happen, because you will get get a screen for clinical data. You can look at your report and put in your bone marrow blasts. If you can find it on the report, good luck with that too, because sometimes it's difficult to find. Put in your hemoglobin. Well, wait a minute, but doc, I got a transfusion. Do I put in my hemoglobin before the transfusion or after the transfusion? Put it in before. Put in your platelet count. Then it's going to ask you for more complicated information, cytogenetics. Again, you're going to have to read about how to interpret your own cytogenetics. I suggest doing this in the office with your doctor rather than on your own. But then there's going to be molecular data to be inputted into this, which is actually kind of subtle to interpret. And there's a screen called loss of heterozygosity at the TP53 locus, which is a challenge to figure out how to fill that out. I cannot explain that to you on this call. It's complicated biology, but if you figure out how to fill out all of these screens, and trust me, I have doctors calling me for help in inputting the information, so it's not so easy. But look, it's kind of a nightmare because it gives you 3 different risk assessments using the IPSS-M, which is the new one using molecular data, the IPSS-R, which is the one that we have been using, and the IPSS-R that is adjusted for age. And they are showing that this particular patient had a risky disease, but I don't know, I'd rather have something that would be, I guess, high rather than very high. And what do you mean? It's high risk, it's very high risk. Which of those is it? And what does that actually mean for me? Well, if you take a case example, so this is Amr Zaidan, who is a fantastic MDS doc, and a friend of mine from Yale shared this slide with me because he put in a 66-year-old female with a new diagnosis of MDS and put in the blood counts and the marrow findings and used all of these different calculators. And this is really hard to read because some of the data give you a risk. Is it high risk? Is it very high risk? Some of them give you a median overall survival. Some of the scoring systems give you a risk of transformation to AML at certain years, a 28.2% chance of transforming to AML at 1 year. How do you reconcile that with the score next to it, which is called a probability of overall survival at 1 year? This is mind-bogglingly difficult. And this is actually what you can and shouldn't do to yourself online. We want the molecular data. It's important. It might be informative in your treatment, but we are in the field in the middle of a really hard mess to try to figure out exactly which classification to use. And not only that, if you think back to what I was saying before, these classifications are in the context of our currently available therapies. If we have a therapy that is particularly wonderful for one of these newly diagnosed mutations, all of this gets blown up. And all of a sudden, the probability of leukemia-free survival and overall survival changes dramatically because the therapy works. So this has to be taken into the context of existing treatments. And what it should be, and what I want this to be, is a real plug for clinical trials. Because if the currently available treatments lead to success rates that are not what you want to see, we need clinical trials to do better. Now, this slide, which my colleague Dr. Zaidan also was part of making and is in a recently published paper, is very important too, that there's live longer and there's live better. And the disease biology, looking at sequencing, looking at risk stratification, doesn't necessarily solve the problem of the patient's age and medical comorbidities and other aspects of quality of life. And I have patients who have absolutely risky disease by IPSS-M, but who have pretty normal blood counts, haven't needed a transfusion, and look fine. Am I going to take somebody who looks fine right into a stem cell transplant? Probably not. I also have patients who are coming in who actually feel fine and they look fine, but they are 25 years old and the molecular abnormalities are telling me that maybe I would take that patient in sooner. So it does take some medical art here still. These classification systems are not the be all and end all. There are different ones. They have slightly different features to them. They don't necessarily tell the full story. For treatment goals, we have to be thinking for an individual patient, what am I trying to do? Am I trying to just get blood transfusions to be fewer, to decrease the impact on the quality of life. If I have patients even in their 60s, 70s, 80s, 90s, nobody is psyched about running into a stem cell transplant at any age. But for patients who are older, can't we do things to make the marrow better? Or if we can't, what are we trying to do for the higher risk patients? Is there an opportunity to use things like hypomethylating agents, azacitidine, decitabine? Might there be a curative option with transplant? Here are the treatment options for MDS. I want this slide to be a lot longer than what it is. We don't have that many toys at the moment. We have erythropoietin stimulating agents. We have lenalidomide, luspatercept, hypomethylating agents are approved. There are a variety of immunosuppressive therapies that might be good for patients who have overlap syndromes with aplastic anemia. There is transplant, but guess what? Transplant isn't 100% curative either. So even though we tell people that it's the only curative therapy, we have to be specific for an individual patient. How likely is it to cure you? There are other things out there, venetoclax, eltrombopag, the IDH inhibitors, which aren't specifically approved for MDS, but which are under consideration based on clinical trial data. And then, of course, we have clinical trials. So there's a lot of optimism in that we are doing much better than we were years ago for MDS. We have many more options. They are more successful and people are doing better, but we want more. The patients, everybody on this call wants more. And we actually want to be we want to be pushing the envelope, making clinical trials accessible and having them accrue quickly so that you all can get the answers to what you want to know. And in particular, to shift quickly the risk stratifications to mirror the available therapies, because it's happened in acute leukemia. We already know that, for example, acute leukemia patients with a FLT3 mutation used to be considered among the highest risk patients. They weren't doing well. They scored absolutely poorly on all of these risk stratification tools. And then we got better drugs for FLT3 mutations, and all of a sudden the risk stratification changed. So risk stratification is fundamentally linked to what treatments we have available. So I saw this joke on I was sort of messing around looking on the internet, and I hope that you guys take it the way that I mean for it to be taken. So this is what happens if you get a second opinion in MDS. I visited a fortune teller at a fair. She was grumpy, and she told me I was going to die within minutes. I walked out of that tent and tried to find another one for a second opinion. She was quite cheerful and told me I would live forever. But I didn't really like either of those outcomes, so I kept looking around and I just couldn't find a happy medium. I hope you think that's cute. I did. I feel like this happens to me in the office multiple times a day. I would like to acknowledge, if I can move the slide, all of my fantastic colleagues at Weill Cornell. Some of you have seen them hanging around in the office when you come in to see me. Thank you, everyone, for the invitation to participate. I hope this was useful to you. And I think I'm supposed to stop sharing the screen, and somebody will tell me if there are any questions. Lee, is that correct? Should I stop sharing?
Sure, Dr. Roboz. Thank you so much for the wonderful presentation, and we have a few questions. Our first question is, how were the genes chosen for the IPSS-M calculation? For example, you mentioned DDX41, yet it is not part of the tool.
So there are emerging data from large sequencing projects to try to get as many patients as possible with MDS from large databases sequenced. And then what we do is the developers of the IPSS-M tool are using very complex computer modeling to try to see, when they put together all of the both clinical and pathology information that's included in there. So you have things like cytogenetics, you have blood counts that are included in there, what falls out at the end of the statistical analysis as meaningful for driving prognosis. prognosis. So there can be mutational abnormalities that are important that didn't fall out as a driver of prognosis in that particular risk stratification tool. And actually, if you go to the different tools, you'll see that they're not exactly the same. Certain mutational abnormalities are important in MDS, everybody agrees, but even within those, there are subtleties. For example, TP53 mutations are widely acknowledged to be unfavorable in terms of prognosis, and yet even there, is it a single hit mutation? Is it a double hit mutation? What is the variant allele frequency of the TP53? So even looking just as there's kind of no free lunch in looking at a mutation. We know that for RUNX1, for example, which is generally associated with a more difficult prognosis in both MDS and in AML. Sometimes that has a familial component to it, sometimes it absolutely doesn't. DDX41 can have a familial component to it, but actually be associated sometimes with an indolent course in MDS. So it's mind-splittingly hard right now because I would say nothing is an absolute. There's no just plain old, this is just plain old good. SF3B1 mutations, for example, are frequently associated with only anemia as the major problem and with very, very high rates of response to luspatercept. That's great, except for an individual MDS patient, if there are concomitant mutations that go along with it or concomitant cytogenetic abnormalities that go along with it, that might change the simplicity of the statement. The answers specifically about how the machine learning algorithms are generating these prognostic scoring systems is particularly interesting because, again, the computers are getting very, very savvy. And if you shove in a ton of data for patients, they will kind of pick out these, and I am by far not a machine learning expert, but there are ways to cull through all of the data and pick out what looks like it's relevant prognostically. But here too, the computer, it's, what did we used to say? Garbage in, garbage out. The computer can only deal with the data that it is getting. And in the same way as in the example that I just said, FLT3 abnormalities used to be associated with an adverse prognosis in AML. If you look backwards in time to the risk stratifications for AML, it was always listed as bad until the treatments got better for it, and now it isn't. So I suspect that we are going to be entering an era of that for MDS as well.
Thank you, Dr. Roboz. Our next question is, it seems that TET2 mutation is not a factor in the new scoring system. Is that correct?
So yeah, TET2 is an interesting one because TET2 can be often associated with something called clonal hematopoiesis. And the subtlety here is that there are mutational abnormalities, for example, in TET2, in DNMT3, that are even more difficult to classify because you can have patients with MDS who have those mutations, but you can also have patients with very subtle blood count abnormalities who are getting evaluated for something called CHIP or clonal hematopoiesis. And that actually should be a webinar unto itself. But what we are learning is that there are patients who have very subtle abnormalities in their CBC where there might be an associated mutational problem. So you might have a DNMT3, you might have a TET2, but you might only have something called an elevated MCV, mean corpuscular volume, or an elevated RDW, red cell distribution width. What we are trying, and what I think the brave new world is going to be, is to take patients with very subtle abnormalities and follow them prospectively to see that are some of these mutations just going to hang out and never bother you, or are some of them having an increased likelihood of progression? And we do think that is the case. For example, spliceosome mutations, JAK2 mutations, U2AF1, sometimes IDH mutations typically have a shorter course when they are detected to progression. My group has looked at this and has published on what we're calling the pre-leukemia landscape. In the future, the hope is to try to identify patients who might be targetable for early intervention before MDS would ever develop. There are actually some clinical trials already going on to try to see if there's any early intervention strategy to prevent this disease. But I caution you, there are many, 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 many patients who have detectable mutational abnormalities. These are age-related. And the point is not to jump on a TET2 or a DNMT3 or something that could be what's called clonal hematopoiesis and all of a sudden launch into MDS-related therapy. It might not be needed at all.
Thank you. Is the goal of the IPSS-M to replace the IPSS-R, or will they be used to complement each other?
Yeah, so at the moment, it is likely that, so at the moment, it's complementary. The problem with IPSS-M is that, again, it's not, it's new enough that it's not adapting yet to what's happening therapeutically, and it's not, we don't really know what is happening over time yet. So a lot of the value of these new systems only becomes clear when they have the test of time, that how is it performing? These are, again, retrospective data. What we need to do is prospectively start seeing how this performs in the context of new treatments. I have to say that on an individual patient basis, I think what many of us in the field have been doing is looking at all three calculators, trying to put together what we think most likely fits along with the pattern of what's going on with the patient, and then come up with a treatment based, I would say, much more still on clinical factors than on IPSS-M. I know my colleagues in the field have a lot of trouble taking patients, for example, who have nothing going on clinically and picking a treatment for them based only on the IPSS-M, that the patients are going to be watched, they're going to be monitored if they have high-risk features, but to put patients through upfront risk of therapy without knowing yet that jumping in early is going to necessarily help, I think is really hard. And I do think if you plug in your own numbers, it's by definition, you're going to get all three. The IPSS-R, both the age-adjusted and the not age-adjusted, are available on the same screen with the IPSS-M. And sometimes those results are actually quite different. And sometimes patients will say, okay, they'll use their IPSS from 5 years ago, and then their IPSS-M now, because there's new mutational data, those almost always look different. And again, I would be very, very careful to, I know it sounds like a crazy analogy, but sometimes, I don't know, teenage girls will get on the scale in the morning and they will decide how they feel all day based on what their weight is. You don't want to do that. If you feel fine and are doing well and you have good blood counts and all of a sudden there's a shift in your risk stratification system, I would not jump and react to that. I would, if you're doing well, your doctor thinks you're doing well, your numbers are okay, you're looking okay, don't jump in and all of a sudden transplant yourself because the IPSS-M computer spit out a different assessment for you.
Thank you, Dr. Roboz. Our next question reads, what would SF3B1 E622D mean?
So different mutations are actually, when you get back a gene mutation, there are within certain genes, there are specific individual mutations that can happen. And this happens frequently that, for example, TP53 is the classic one that people will get back a TP53 mutation and say, oh my goodness. And there are certain locations of specific mutations that may or may not have prognostic significance. So within all of the different mutations, you will get back a lot of information related to the location of the mutation within the gene. And then that may or may not be therapeutically or prognostically relevant. Genes can be mutated in different spots in the gene. And this is where people go into things like the COSMIC database and some of the large publicly accessible databases to try to figure out whether a specific mutation has actually prognostic or therapeutic importance.
Thank you, Dr. Roboz. We have two questions about MDS. The one question is 5q deletion less likely to develop into AML?
So again, it depends whether it's an isolated 5q or whether it's a 5q abnormality that is associated with other cytogenetic and molecular risks. Isolated 5q often has a quite indolent prognosis or slow-moving prognosis in MDS, and many of those patients with isolated 5q have significant anemia, and for that, there is actually an FDA-approved therapy called lenalidomide. There are some emerging data from a newer clinical trial asking the question whether using lenalidomide even earlier for patients with isolated 5q or even in association with other abnormalities before they get anemic, that is there a role to using lenalidomide early for those patients? And so far the data suggests that it may slow down the risk of needing transfusions if you use that drug earlier. That said, with respect to AML risk, the answer is it depends, because a 5q in AML, as the author of the question may know, is associated with adverse outcomes, whereas a 5q in MDS has been historically associated with better outcomes. So it depends on whether or not there is a concomitant TP53 mutation or other cytogenetic abnormalities. And Lee, I'm going to be able to take one more question.
Yep, we only have one more, Dr. Roboz.
Perfect, perfect.
Perfect, it worked out well. Our next question is, are continued bone marrow biopsies recommended to track changes for alternative treatments?
So that is a great question and a perfect way to end. I don't think that digging for pain, literally, in serial bone marrow biopsies to watch variant allele fractions or to watch mutational abnormalities has been shown yet to be of any benefit. I would say on clinical trials, we are doing serial marrows to try to learn whether there is any, for a novel agent, whether there would be any benefit to more close monitoring. But in general, I think that what I like to do, I always do a bone marrow biopsy if I'm switching therapies, because I want to know exactly what the marrow looks like beforehand. If somebody is on a growth factor or on a medication and then stopping, I like to wait, ideally for a week or two before doing a bone marrow biopsy so that there's no kind of leftover effect of the prior therapy, especially growth factors. And in general, the utility of a bone marrow biopsy is if we are contemplating a change in therapy. I think for routine monitoring, I am concerned actually that if someone is doing well clinically, there might be subtle ups and downs in the bone marrow that can result in some whimsical management that might not actually help anyone. You have to understand that some of these testing for flow cytometry, for blast count in particular, can be very, very changeable from one test to another and not necessarily mean much about what's going on with the patient. So clinical features first before going in for serial monitoring.
Well, thank you so much, Dr. Roboz, for your time and your expertise in sharing all this wonderful information with us. If you'd like to watch this webinar again at a later time, it will be available on our website within a few business days. If you have any additional questions, please send us an email at help@aamds.org or give us a call at 800-747-2820. Thank you again, Dr. Roboz, and we hope you have a great day.
Thank you so much, you too.